my slides, and then we can just go through it all. Right. So can everyone see my screen? Okay. If anyone can see my screen, then that's helpful. It just tells me I'm on the right track. Has anyone got a PowerPoint screen in front of them?
Yeah, I can see it.
Great. Okay. So, if it flags up anyone's trying to join this evening, could someone else admit them? Just because I'm not sure if I can admit them if I'm on a different screen. So if you see someone trying to muscle their way in, then please be kind and admit them. Right. So your exam, there's a written exam and a practice exam. Practice exam consists of 2 stations. There's a medical and a trauma scenario. So a medical scenario might consist of anything from a heart attack to asthma, anaphylaxis, low blood sugar, stroke. A trauma scenario is going to involve head injury, C-spine injury, chest injury, abdominal or pelvic injury, using the traction splints, etc. And you've got to pass both those stations, and then you've got to sit a theory exam, which has got a 60% pass rate, and that's been confirmed to be the pass rate for this year as well. Off the top of my head, the written exam is approximately 1 hour in duration. And then, if you pass all 3 components, you can move forward. There are some errors that you are allowed to commit, which will allow you to resit either the medical or trauma scenario later on the same day. So, if you make a slight blunder on the medical trauma scenario, and the examiner feels that it was not worthy of a pass, then you'll have the opportunity before the day is over to resit not the same scenario but another scenario of either medical or trauma, whichever one it is was you failed. There are some errors that may be deemed, if they're deemed by examiner to be deemed to be directly harmful by doing something sort of that would be actively harming a casualty, which puts you as an outright fail, and you're not allowed to resit the same day, and you have to wait, I think it's a year before you can resit the exam. I'm not aware that that's ever happened, and with good training that should easily be avoided. Generally, people just require the 1 episode, or they may, on the second rerun, they may make a marginal error again, which means they have to resit the exam without the 1 year delay. But it is theoretically possible that a seriously harmful fault may mean that you have to defer it for a year. I'm just letting you know, just as that's what I've come to understand from going through the syllabus. The practical exam, so the 2 stations, you're expected to do a primary survey, come up with some form of a diagnosis, and then make an appropriate action plan. You may be asked to demonstrate some skills such as drawing up and administering intramuscular drugs, connecting a nebulizer, oxygen cylinder, all of the skills that are on that core skill sheet that you should all have a copy of. They are ones that you may be asked to demonstrate throughout the course of the exam. Obviously, the ones that aren't going to happen. Obviously, the ones that aren't going to be asked to do is things like putting someone in a vac mat, because that's just going to take some time. Just because I'm flitting between screens, if anyone wants a question, just unmute yourself and ask a question. That's absolutely fine. Just because it makes it a bit easier for me to navigate my way through it. So how to pass? So this would be my key to success, which is essentially it's all about the primary survey. So as soon as the examiner sees you make contact with the casualty and start to run your primary survey, they'll know very, very quickly whether they're going to sit back and relax, and they're going to allow you to guide yourself into a pass, or they're going to know very quickly whether or not you're clearly quite rusty, and they're going to have to watch you like a hawk throughout it. It makes a really slick primary survey just makes everything so much more simple. It reduces the stress on your head because you're not having to think so actively throughout the course of the primary survey, and it puts your examiner at ease. So I can't emphasize enough how important it is to have a really slick primary survey. Probably one of the most important aspects. Don't administer drugs without asking for a drug card, and while around it, don't administer a drug without asking for an allergy of the casualty, and also take your time. There is a time limit, but it's about 15 minutes, and it's actually quite manageable. So just take your time, don't get stressed, and work your way through in a very systematic way, and you'll be fine. I don't know if everyone's got a copy of the syllabus. This is the syllabus for those of you who don't have it. The date is old, but it still remains the same, and it's a pretty hefty document, and it shows all the skills and bits of information you're expected to know. It's quite nauseating to read just how much there is there, but it's useful to flick through. I've sent it to my guys, and if any of the guys who aren't a USO want a copy, you're more welcome to have it. And really the purpose of these sessions is to address some of the non-practical skills that may come across, so that because they aren't taught as often during the practical sessions that we run, so this is an opportunity to go through some of that more waffly stuff that may come up in your written exam. So we may as well just get straight into it. So 2 mnemonics that you're expected to know through the exam. So number 1 is the Chalet scene assessment, and the second is Atmist, which is just here. So Chalet is a scene assessment mnemonic, and it's used to sort of try and help a controller help to run a major incident. There is another acronym called Methane, which you may have heard of. Both of these are mentioned in the Cascare syllabus, but Chalet is the one that's really gone into any more detail. What it stands for is casualties, hazards, access, location, emergency, and type, as it's all listed out in front of you. It's all relatively straightforward. This isn't something that you would expect necessarily to be doing in a practical exam. Well, it's not actually, but it's something to be aware of for sort of practical skills if you end up taking on more leadership roles. But secondly, for your written exam, although you wouldn't be expected to know the real ins and outs of what does every letter mean. Well, actually, I say that. I seem to remember that there may have been a question in the past where it does give you a list of words, and it asks what the acronym stands for. So it would be worth just being aware of that. It's going to be one of 3 acronyms, unfortunately, you've got to memorise, because obviously there's Chalet, there's Atmist, which we'll get onto in a moment, and then there's also your sample, which will be part of your primary survey. So this is something to have down in your sort of cheat sheet, if you like, in terms of revision, just to have an idea of an awareness. So, casualties, we want to know how many casualties, what degree of injuries there are, and what sort of kit might therefore be required. Hazards, so that's hazards to present casualty carers that are going to be accessing the area, or ongoing hazards to the casualties themselves. What access routes there are, whether that be by land, by water, by air. The location of the scene, what one would hope with a grid reference. And then emergency, so that stands for sort of what services are actually there. Are the paramedics? Is it just mountain rescue? Do you need other more specialist teams or equipment there? And then type is a bit more of a generalized description of the event that's happened. AtMist, so this is a tool that's quite useful to be able to hand your casualty over from your care to the care of someone else. That may be to the care of another casualty carer, or it might be to another service like the ambulance service. So it's actually not unreasonable that this may crop up in real life. Anytime you're a casualty carer, if you're a lead casualty carer, it's expected that you'll have to hand your care over to your patient to another service, and unless you're particularly slick at doing it, this is a nice acronym to use. So A is just basic demographics, so age, name, date of birth. T is for time. M, mechanism of injury, so fall, stumble, sudden onset of chest pain, stung by a bee and has developed an allergic reaction. I is for essentially the findings of your primary or secondary survey, so what injuries have been sustained. And then S, so signs and symptoms, so what the casualty is complaining of, and what abnormal examination features you've seen, so heart rate, pulse, saturations, etc. And then finally T is for treatment given, so you want to be recording dosages of drugs and the time that it's been administered. So that's another acronym to be aware of. And again, this is something that could come up in your written exam. So, any questions so far? So moving on to it's a bit all over the shop this training tonight, I'm afraid. It's kind of just trying to get in lots of topics that may come up to try and improve your chances of passing the theory test. So sorry if there's a bit of chopping and changing. So next, we're going to talk about the triage sieve. So again, I don't just want to read slides out to you, but the whole purpose of a triage sieve is that if you attend a scene where there's multiple casualties, it's a way of very rapidly assessing the degree of injury and the stability of each casualty, and to some degree the level of survivability of their condition, to be able to quickly rank them into how you're going to prioritize their care, so that you and your colleagues can focus your care in the most efficient way to save the most lives or reduce the most harm as quickly and efficiently as possible. So there's four main numbers. So number one is the immediate. So these are casualties that are generally going to have an abnormality found on your primary survey. So this could be a potentially occluded airway, a chest wall injury that urgently requires oxygen, a hemorrhaging limb which you can reverse by stopping the bleeding, and therefore a small intervention would lead to a significant reduction in sort of harm or death of the casualty. So these are the things we're going to pick up on our primary survey, although that isn't, you wouldn't be doing a primary survey on these casualties. It's a quick eyeball. But when we talk about immediate, we're talking about the types of abnormalities that you'd be looking for in your primary survey. So big, major injuries that you can intervene on quickly to make a big difference. Secondly, we've got our urgent casualties. So these are casualties which, as listed here, are relatively stable. They're unable to walk, but they have comparatively normal physiology. So all the numbers are okay, and you know they're going to need treatment, but they may only need treatment within a few hours. So the next few minutes is not going to make a big difference to them, but the next few hours certainly is. So that's going to be into category 2. Category 3, we're moving on to the delayed category, or the walking wounded. So these are people that you're going to put right on the back burner. So some more minor musculoskeletal injuries or grazes or burns, and this is stuff that you can sit on for several hours if you needed to. So here the definition is 4 or more hours, and you can park them somewhere else safe, and you can relatively safely ignore them. Obviously, the caveat to this is that you need to keep an eye on your triage sieve, because it may well be that things aren't presenting to you in the first presentation, and you may need to re-review. So it's not a case of, that casualty is, we're going to put them in the delayed group, we're going to ignore them for 4 hours or more. Ideally, we're going to keep a rough eye on them, and we're going to reassess the status of them, at regular intervals, to make sure that we've not missed something on the first primary survey. And then finally, we've got our final categories. So category 4 are expectant casualties. So these are our casualties that have got such significant injuries that it's unlikely that with the resources that are available and the situation that we find ourselves in, that we're going to be able to make any meaningful chance of survival for them. And therefore the difficult decisions made in this situation, that we won't offer them any intervention, and we will unfortunately have to bypass them to go and look after our immediate and our urgent casualties. So here we're talking about really quite devastating injury. So really quite significant trauma, maybe complete evisceration of the abdomen, so the whole of the abdominal contents is hanging out, or there's such significant chest trauma that we're thinking that there's no way that we're going to be able to offer any form of treatment. And there comes a very difficult decision about having to put casualties into this category. So there are colours assigned to these codes as well. So red for immediate, yellow for urgent, green for delayed. So doing a traffic light system, and then blue for expectant, and then black or white for casualties who are already deceased. So here are some examples I've drawn up. So we've got 6 casualties here, and let's have a little talk now about how we might think about prioritising these patients. So I'll just read them all out, so we're going at the same pace, and then if people just want to afterwards just speak out, we're all learning for the same exam, so a bit of interaction would be nice if possible. But we'll then have a think about how you prioritise this. Someone got a question? So number 1's got male, 10, ankle injury, shouting out in pain, ankles at a funny angle. But his pulse and his nerve in his foot are both fine, and the rest of his ABC assessment is also normal. Next, we've got a female with a head injury who's got some oozing blood. She's alert, conscious, with a graze to the left side of her head, and her ABC is normal. We've now got a female with a head injury who's unconscious, with a snoring noise, with a small amount of blood on the floor. Next, we've got a male with a deep open wound to the thigh with a large volume blood loss. His heart rate is 120 and his respiratory rate is 30. We've got a female with evisceration of the abdomen responding to pain. So what we mean by that is that there's been a significant injury to the abdomen, and all the abdominal contents are now outside of the abdomen. And then we've got a male who's got amputation of 2 limbs with catastrophic bleeding, with no pulse palpable, and he's unresponsive. So, who wants to share some thoughts on what kind of casualties we've got here then?
Let's say hi Patrick, it's Mark. Is the bottom one pretty much dead?
Okay.
Evisceration of the abdomen, I'm thinking that could be your expectant. So I would then go with the catastrophic bleeding for the male deep open wound is the first priority.
Okay.
Mm-hmm.
Then with the female head injury closely behind.
Okay.
And then put the female with the head injury above the male with the ankle injury.
Okay. So you've gone nicely in reverse order there.
Yeah, sorry.
No, not at all. Does anybody? Would anyone be? I don't want to challenge Mark's decision.
I would possibly challenge the bottom one. With catastrophic bleeding, you might not find a pulse, but if he's actually bleeding, then the heart's still pumping, and I would be looking at getting the bleeding stopped, possibly. So I put that as immediate. Certainly until we can confirm that there is no pulse, either through a pulse oximeter or whatever.
Okay. What about the rest of it? You happy with the rest of it? The second one, female head injury, I would park that, but reassess at the second triage. Same with the ankle injury, obviously. Park him immediately, but reassess in the triage, so that you wouldn't forget them for the 4 hours, but certainly park them for a second triage while you're dealing with the third and the fourth, and number 6. Six, yeah. Okay. Anybody else who got any different opinions?
The milk isn't too hot that it scrambles the egg.
No. Okay. So I think the question about this patient with catastrophic bleeding. So I guess there's probably an error on my part, because you both make a very reasonable argument. So maybe I should have written that, and then sorry, I didn't catch the name of the who spoke second, but would that help you park into Mark's camp?
Yeah, I think so. Yeah, I mean, I read it as there's an ongoing bleed, which would indicate some heart activity, as opposed to a big pool of blood and nothing, no actual bleed.
Yeah, I would agree with you in the sense that it left some ambiguity, didn't it? So if there's still stuff pouring out, then maybe we should try and put something back in. I suppose what we could say in the counter argument is, if we're in this rapid triage setting whereby we've got to make a decision as to what our resources are and what we can do. If we turn off the tap for this guy and we haven't got a pulse anywhere, we're not going to be able to top him up anymore to improve his circulatory system. But I think that for the purpose, and this is why these questions get moderated. So had someone written the question the way I originally labelled it, I think it would be entirely fair to have ambiguity. What I'll do is I'll rephrase it the way I've done it here. So catastrophic blood loss, no pulse or unresponsive, and I think we can all be comfortably singing the same hymn sheet. Is that fair to say?
Yeah.
And then I think we put the next lady in the expectant group. I think that's fair. There's really nothing we're going to be able to do for this lady. There's nothing in our primary survey kit bag that's going to help us put her abdominal contents back into her abdomen. In terms of the next guy, so here we've got this sort of perfect scenario of someone who's got a really acute problem that, if left over a matter of minutes, is going to cause serious harm. So this is really a good way of us breaking off our primary survey, and I will completely agree that this is going to be in our immediate category. And then there's a bit of a debate as to female with a head injury. She's unconscious but snoring. So with that snoring sound, so that's suggesting to us that there's an obstruction to her airway, and I'll go on to that in just a moment. So we think to ourselves, well, wait there. So if there's an obstructed airway, that potentially could be reversible. So then you're left with a slightly difficult situation, as if you're there by yourself, you just got your own pair of hands, then doing one of our head tilt, chin lift, or other manoeuvres, that's going to tie you up then, isn't it? So you can't hold her airway open for the rest of the time. But then what about if we had an airway adjunct with us, and you pop that in, and she responded well to it, then you've made a quick fix that you can move on onto, and there's nothing more you can do about her at the time being. It's her conscious level and her airway that's the issue. So an oral airway would potentially fix that, and you can free yourself up. But if you haven't got an oral airway, you get yourself into this dilemma of, well, what should I do? Maybe put her in the recovery position if she's lying on her back. So I think there's some debate. And then I would agree that the top two categories are. I certainly think that the female with a head injury with some oozing blood is a relatively clear-cut case, and I would very much support the opinion that she needs a reassessing. And then, interestingly, so this first category is important, because this is all about casualties who can distract you from your job. So we've talked. Some of you may have heard the phrase of patients who have distracting injuries. So they've got a very, very painful part of their body that they're so much pain with that they're not recognizing that they've actually got a really lethal injury elsewhere, and so we don't find that other injury. Now, in this situation, this casualty is being a distracting patient. So that I think it's fair to say that there's no limb or life injury at risk to this casualty, from what we can see. But they're potentially going to drive a lot of attention to themselves, because they're the ones making the most noise, and so it's important that in this triage setup that you remain focused, and you're like, yeah, well, I've seen what I need to see. They are in pain, but at the moment, getting their pain under control is less important than stemming the blood loss from that person's thigh, the fourth casualty, and that's part of this sort of triage mentality. Any questions or thoughts on that?
Patrick, just one question. Have you, for the last two, leaving them at level 4, essentially, does that decision also depend on your resources available? Because if you categorise them as a 4, is there a risk you're just going to leave them, and then if you've got enough resource, are you got enough triggers to then go back and reassess them?
So I think that we're saying that probably the last patient is probably dead, with the way that we've reworded this now. So there's no ongoing bleeding. They've had a catastrophic hemorrhage, and we can't find a pulse. So in normal circumstances, we'd refer to that as cardiac arrest. So we need to start trying to resuscitate them. So we're gonna. I think we'll say that casualty is dead. In terms of the other lady, so this is a difficult decision of once you've made that assessment, what you are in essence doing is saying that until there's any significant change in your resources that are available, that you aren't going to pay any more attention to that casualty. Now, obviously, if you know if 10, 15 team members or paramedics just rounded the corner and were at your disposal, then you would clearly redirect your resources appropriately. But this is part of the triage shiv. It's to work out that you know that in the coming half an hour, that you and one other person are not going to make any difference to that casualty's lifespan, and so therefore, yes, you're essentially going to park that and continue your job until the circumstances change.
Great.
Does that not depend on location as well?
How do you?
Well, on the side of a road by a big car crash is very different to being on the side of a mountain, isn't it?
Yeah. So I think that your triage sieve is dependent on everything. It's dependent on your resources. It's dependent on your geographical location. But I suppose that the mindset of the triage sieve is that you turn up single-handedly with a small kit bag. And you have to make an assessment of a large number of casualties. Now, if you were by a road, then yeah, I mean this casualty will have a higher chance of surviving. But if you've still just got your kit bag and you're still by yourself, it's still unlikely that you're not going to make any meaningful difference to their care. Obviously, if more resources arrived and you were going to be able to evacuate them quicker, then your triage sieve might have to be reset up. But the whole purpose is just a quick glance. What's the most amount of impact I can do in the shortest amount of time? If that makes sense. Anybody else have any thoughts or questions on that? Okay, all right. So we're going to, in a not very smooth way, we're going to move away now from our triage sieve and start to run through some rather painful anatomy, because the syllabus wants you to have a knowledge of essentially most of the important anatomy that's required. So we're going to start to go through most of the anatomy that you're going to need to know. So we'll start off top and work our way very slowly down. So here we have a cut through of a head and a neck. So we have our nasal cavity, we have our mouth cavity, and we've got our tongue, and then at the back we've got the space where the two of them meet, and then in the front we've got our windpipe, this rigid tubular structure that you can feel the trachea on yourself if you feel in front and center of your neck, this sort of ribbed tubular structure. And then behind that there's this collapsed food tube called the esophagus, or your gullet. And that's the very rough anatomy. And why this is particularly important to draw your attention to is that all around here, so all around the back of your mouth, all these structures here in the area we call the oropharynx and the nasopharynx. So this is all just soft tissue. So there's nothing really bony or hard keeping these airways open. So if there's a significant reduction in conscious level, whether that be through trauma, through a medical complication or whatever, then there's the ability for these bits of soft tissue to sort of fall back and collapse in on themselves, and that can sort of begin to obstruct the airway and stop air from passing from the environment down into the lungs, and vice versa. This is also a real problem because we'll talk at a later point about allergic reactions. But when we have a serious allergic reaction, as what we call anaphylaxis, we can get a lot of swelling in the soft tissues in and around the mouth, the nose, and the lips. And when these tissues begin to swell, they just they just fill up the empty space that's around them. And the empty space that's around them is the airway. So it's this passage from the environment to your lungs. So if you've got really bad swelling, and I'm sure you will have seen pictures of people who have been stung by a bee or have had nasty allergic reactions and their faces all swollen. On the outside, okay, the lips can go out, the lips can protrude outwards, but any swelling on the inside is just going to make this red area smaller and smaller. And that's why, and that's one of the more serious that's one of the mechanisms by which serious allergic reactions end up killing you, because you lose this passage from the environment into your lungs. And again, it will focus it more on the specific discussion around allergic reactions, but reversing that swelling using drugs like adrenaline is a really important tool that we've got in our kit bag. So the nasopharyngeal airways, which if you haven't had a chance to get your hands on yet, you will do as part of your skills, is sort of a long, sort of thin cylindrical structure that passes up through the nose and rides itself and comes and parks itself towards the back here. So it basically passes up through your nasal cavity. The oropharyngeal airway comes and sits nicely round over the tongue and will exit about here, where it then passes out into this big open structure. The reason why you may well have heard talk about why the nasopharyngeal airway or the oropharyngeal airway, the Goodell airway, is less tolerated if you're more awake. Is because around here, some of the nerves that supply this area are what supply your gag reflex. So the Goodell airway, the oropharyngeal airway, will sit around here and will irritate your gag reflex, which is why it's not tolerated. The nasopharyngeal airway will sneak its way, park itself about here, and will although it will be uncomfortable, it will not irritate that sort of reaction that you have to just to move it. We then make our way down, and we come down to our trachea, our food pipe, and then we enter the chest cavity. So right at the top, you've got all your main blood vessels. So the aorta, the main blood vessel that goes from your heart to the rest of your body, supplying it with blood, and then all the blue vessels bring blood back from the other parts of your body back to the heart. And you've got these two big airbags either side of it, called your lungs, which obviously inflate and deflate as you breathe, and they transfer oxygen into your blood. And then moving down into the abdomen, just tucked underneath on the right hand side, you've got your liver, and tucked underneath your left hand side, you've got your spleen. Don't know how well it's actually shown on here, but the spleen is tucked in round on the left hand side, with the stomach lying just beneath it, and then lots and lots of bowel lying throughout the rest of the abdomen. And now people often think that the bottom of the rib cage, if you actually have a feel on your chest at the moment where the bottom of the rib cage, there's often a misconception that that's where your lungs end, and then all the rest of the abdomen is then tucked underneath your lungs into that squishy part that's your tummy. But as you can see here, the liver and the spleen are actually protected. So on this margin here, we can see where all the ribs have been cut off on this diagram. What we can see is that the ribs would come over and they actually protect these really important organs in the cage. So where you can feel your ribs end and your tummy start, that's really predominantly stomach and bowel. The liver and the spleen are tucked underneath there, and your lungs at the front start a bit higher. Why are these important? These two organs are particularly important because they've got a really, really rich blood supply. So if you have damage to the organs themselves, they can bleed and they've just got this huge big space of just lots of squish and goo of your bowels and other organs where it can just bleed into, and you can end up bleeding the majority of your circulating blood volume into your abdomen. So that's why the body is nicely evolved to have these protective ribs that cover them up. If you flip the chest the other way around, you can feel your ribs going down at the back, either side. The lungs actually go lower down at the back than at the front. So the liver and the spleen are at the front of the body, and so at the back you've actually got your lungs that come a bit further down to where your ribs kind of end. And just beneath either side you've got your kidneys as well. So your kidneys are at the back of the body. And they, I haven't got a picture here for some silly reason, but any trauma to the left or the right of the spine has a risk of injuring your kidneys. They also have a very rich blood supply, and they're a risk of causing blood loss. So just a bit about how it all works. So when you breathe in, the diaphragm, which is this flap here, I'm tracing with my cursor. So this big muscular flap that pulls down, and the chest and the ribs open up outwards. And what that does, that lowers the pressure in these two big wind bags, and it sucks air in from the environment into the mouth, down into the lungs. And then when you breathe out, the opposite happens. So the diaphragm relaxes, it pushes upwards, the chest wall closes in, and it compresses the lungs, increasing the pressure in the air in the lungs, and that forces air back out through the mouth. And that's the cycle of what we call ventilation, so moving air from the atmosphere and into the lungs. Any questions on that? Not the most riveting stuff, to be honest, but there we go. A little bit about the nerve supply to the body. So the nerve supply is basically divided up into what we call a central nervous system and then a peripheral nervous system. And the central nervous system basically consists of your brain, and then the motorway of nerves and impulses, which is your spinal cord, and it runs up and down the centre of your spine. And the body is very well adapted, so anything that is important is protected really, really well. So you've got a skull, big bony structure that completely protects the brain, and then you've got the vertebra, which are all the knobbles along your back that you can feel, which have got a ring-like structure which the spinal cord runs down. So everything's very, very well protected from any injury. Obviously, if you have an injury to your spinal cord, one of the mechanisms by which this can happen with trauma is that if you imagine that the spinal cord is this sort of slightly squishy tube of nerves that lie within this sort of cylinder of bone that runs up and down the body. So if you have really significant trauma and it breaks that bone can then move forward and will just shear through the spinal cord, and that's what often will cause the injury. And if you look at this diagram, you can see how. So see all these layers that we've got. So the spinal cord. So the spinal cord runs down the middle where my cursor is. And then you're protecting it with bone at the front, bone at the back, and then it sits in a ring of bone as well. And it's divided up into your cervical spine. So your cervical spine, your thoracic spine, your lumbar spine, and your sacral spine. So cervical spine ends roughly at the level of just above the level of your shoulders. The thoracic spine ends probably just at the just at the top of your buttocks, probably a bit higher actually. The lumbar spine is your what we'd refer to as your lower back, and the sacrum is that bit that with that bony prominence that just almost the tip of your spine that you feel as you if you run your fingers down. And any injury that you get, by and large, there's always exceptions to the rule, but by and large, at the level of injury that you get, it means that all of the nerve supply downstream of that injury will be affected. So if you cut the spinal cord here, in the right hand picture, then all the nerves throughout the rest of the body would be affected and would either cease to function or have significantly reduced function. If you cut it here, then all this would still work, but everything downstream would be affected. And the same if you would cut it here, all of the chest and the arms and the head and the neck would be okay, but everything from the waist downwards would be affected. This is why we make such a big deal about, not only just spinal injury per se, but cervical spine injury is particularly devastating, because the higher up the injury, the more of the body that's affected. And then actually the nerves that supply the muscles involved with breathing, so the diaphragm, which was this muscular organ that we talked about before, they actually come out around what we call C3, C4, so up at this level. So if you have an injury above that level, then you actually cut off the nerve supply to the muscles that supply breathing, so you can't breathe, and therefore as a result you would die. So that's a little bit is the reason why the cervical spine from our perspective is so carefully guarded about. Any questions about that? You're probably all deep in a slumber, and you've already all logged off, and I'm just talking to myself now. But anatomy is never the most interesting topic to be talked about.
I'm finding it interesting, Patrick. Keep going.
Moving on, we've then got another squiggly diagram of more and more tubes and pipes that supply the body with things, and this time we're talking about our circulatory system. So for the exam, you need to remember every single one of these words and descriptions, which I'm sure you've realised is a joke, because I'm not sure I could be bothered trying to learn that either. But essentially, the way the circulatory system works is you've got a main pump in the centre of your chest, which is your heart. The main blood vessels are biggest the closer they are to the heart. The red system pumps blood out from the heart around the whole of the body, and then the blue system drains it back from the faraway part of the body back through a separate system into the other side of the heart, where it then just repeats this cycle of going round and round. So same with the nerves. The higher up the injury, so if you were to looking at where my cursor is, if you were to cut the blood supply here, then that means that you've got a spurting artery that is carrying the blood to all of this leg. If you were to cut the blood supply here, you'd still be able to chuck out a fair amount of blood, but the volume of blood that's going to be circulating through that blood vessel compared to that blood vessel is a lot less. And then we come to the discussion about what's the difference between the red blood, the arterial blood, or the blue blood, which is the venous blood. And there are some important considerations in terms of mountain rescue, because if you've got a point of bleeding, arterial blood, or the red blood you can see, or the red diagram you can see there, that's the blood that's coming away from the heart and is under really, really, really high pressure. So if you cut the blood vessel, it will be much more difficult to stop the bleeding, and at the time while the bleeding is happening, you're likely to lose a lot more blood. The venous blood that's coming back to the heart is under much, much, much less pressure. So and that sort of bleeding. So I'm sure many of you will have had your bloods taken, a hospital appointment or a doctor's appointment. What you'll find is that unless you're on other types of tablets, the needle will go into the vein, the blood will come out, you'll press on it for maybe 15-20 seconds, and then you'll have a sticky plaster and I'm brave sticker, and that'll be that. Now that's because it's gone into the vein. If you were to do the same procedure, put the same needle into an artery, the same area of the body, it would probably take a couple of minutes for you to be able to press and stop any bleeding from happening. So that's a sort of a very basic description of why there's a difference between venous blood, arterial blood, and what the significance is of having an injury high up in a limb compared to lower down in the limb. So that flows us nicely into a completely different topic of burns. I hope you're liking the sequence of events that we're going through here. Before I move on, any questions on anatomy? We will be covering bones and breaks at a later point, but that's more of a discussion in itself. Any questions about what we've discussed so far?
I've got one, Patrick. So on the acronym with 12 on breathing, we look at laryngeal.
Yeah.
What are we actually looking for on laryngeal?
So it's interesting that you bring this up, because I know that. So are you referring to the 12 flaps?
Yes.
So 12 flaps seems to be being phased out, and I certainly know that on the Flammeris course that they're not strictly asking people to do 12 flaps. If you've learnt 12 flaps, you won't do harm by practicing it if that's what's in your head. But what? So if we go back to this picture of the head and the neck, if you feel on yourself across the front of your neck, you'll feel a quite prominent bony structure called your Adam's apple, which is just sort of underneath your chin, quite high up on your neck, and that bony structure there is your larynx. Now the 12 flaps acronym refers to laryngeal crepitus. So laryngeal means larynx, and crepitus essentially just means sort of crackly. So you can get crepitus elsewhere in the body for a variety of reasons, but it basically means it's crackling. And so if you feel that, and it basically suggests that bony structure is broken because it's sort of cracking and moving around. It is essentially what it means. It's a very I think they were slightly clutching at straws when they were making the acronym. It doesn't flow very well. But essentially, if you feel that this sort of bony structure up in the neck is all moving around and is broken into bits, then that's essentially what it means.
Thank you very much.
So we'll move on to from anatomy onto some burns talks now. So this rather unfortunately coloured, multicoloured character is what we're going to study next. We're not going to go into any genitalia anatomy. Don't worry, that isn't going to be something that we need to be bothering too much with. So I'm sure, some of you may or may not have seen this diagram before. So this is a diagram of how we assess burns and the significance of burns. In terms of burns, I mean, what are we talking about? So we're talking about when the skin is exposed to significant high temperatures, whether that be from direct heat, whether that be from hot water, hot oil, but actually the actual surface of the skin is damaged and is no longer integral as a result of a thermal of a heat injury. And the reason it's so important is because the skin provides one of the sort of most important defences in the body. So it's got lots and lots of functions, and some of the functions are working. So actually being involved in regulating the body's own heat. So making sure that we are losing enough heat if we're too hot, or making sure that we're conserving enough heat when we're too cold. These are all really important aspects of the skin. They also help to provide a really useful barrier for infection. So that's why if you've got cuts, places, people say you've got to make sure it doesn't get infected, because once you've broken that layer, you lose the integrity, and you risk picking up infections. And there are lots of other functions of skin, which if there's a dermatologist listening to me talk right now that have their head in their hands, I'm not giving you a really comprehensive list. But these are the main things we need to think about. But when we've got a degree of body that's been burnt, we then need to have a little think about how we're going to calculate how much has been burnt, and that's where this diagram comes in. So this is what we call the rule of nines. So everything here, apart from the 1% of the genitalia, is a multiple of 9, and things change ever so slightly for children, but we won't stress too much about that. And obviously in very obese adults there will be a change as well, because there will be an increased amount of skin in the trunk. But by and large, a good, reasonable way forward of approaching this is the rule of nines. So you assess what area of the body has been burnt, and then you apply it to this diagram, and then you can work out from that what percentage, and that's a really useful way of helping to sort of prognosticate or work out how poorly your casualty is, and being able to sort of escalate care, and this is mentioned in the syllabus. So head and neck, if you had a significant area of the head and neck covered, that's 9%. Each upper limb is 9%. Each lower limb is double that, so that's 18%. And then you've got your trunk, so your front and your back combined is 36%. So obviously, if it was all the front or all the back, you could then take 18% for each. With the genitalia, they just put that in, I think, just for the to make sure it rounded up nicely to 100%. So this is a diagram to be aware of, and to have to have it in the back of your mind. And then if we see someone who's had a burns injury, it's important that we know what we're going to be doing for them. So burns, and we talk about the skin, we mustn't forget that we're talking about any form of tissue that's been potentially exposed to that heat. And if you imagine that the airway, so your mouth, your lips and your tongue, all the way down into the interior lining of your lungs, is still a continuation of the air that's being exposed to the environment. So the inside of the mouth and your airway are all areas that can be injured and undergo damage through a burn. And often this is one of the more critical areas that can cause very immediate and severe harm from a burn, because as we talked about before, if you've got all the lining of this tissue, if that becomes burnt, the body's reaction is to send lots of agents via the blood to try and fight it off and to try and make it better. So you get lots of swelling, and then that potentially causes an obstructed airway. So what do? We sit them up, consider giving them oxygen. We reassess them, and if there's any wheeze in the chest, we consider giving them salbutamol. Fluid loss is really important. So the skin provides a really important barrier to the body conserving fluid. So fluid loss is a potential big risk, and that's one of the reasons why we need to act quickly. And it's also worth mentioning that it's going to be very, very painful, but due to the sort of severe injury, blood is being diverted away from the food tract, and so you may get the oral tablets aren't absorbed as well, and we may have to resort to intramuscular or intranasal if there aren't any significant burns to our airway passage. So what are we going to do for them? Well, again, it's all pretty simple stuff. So no particular heroics. Any area that's obviously burnt, we're going to try and cool the body. So we're going to try and cool that direct area of skin with cool water. The guidelines seem to suggest this 20-minute mark is optimal. Now, I appreciate that if there's a significant burn on a hillside, which could happen, that there have been aircraft crashes in the not too distant history of Numera, and that certainly would be a type of environment where burns would be a major component. You're not really going to have a running tap for 20 minutes available to you. So these are all guideline-driven statements, but the practicalities are is that you can only do what you can do, and if a couple of bottles of water is what you've got, then a couple of bottles of water is what you've got. If clothes, especially sort of polyester or plasticky based clothes, have actually become stuck to the skin, they've burnt onto the skin, you don't try and remove that. You can continue to cool it, pour water over it, but leave it in place, because by trying to remove that, you may continue to worsen the amount of skin that's being lost and damaged, and you're potentially removing with it a layer of skin that's at least forming some form of a protective barrier in the short term. Clearly, in the long term, it will have to be removed, but that will be a situation in a hospital situation where that should happen. So if clothing is stuck to it, then remove it. If clothing is loose, it would not be unreasonable to remove that. But then this brings us back to this concept of the skin providing this really important thermal barrier for the body. So if you start stripping them off and they've got large areas of skin that is no longer working, then they're going to get cold very, very, very quickly. And so you have to make sure that with every decision to take off a layer or item of clothing is being matched with some way of protecting them from the elements and protecting them from getting cold. So basically, immediate action is pouring as much and as continual cool water on the affected areas for as long as possible. Administer oxygen and have a mind on an airway management, and try and keep them protected from the elements, stop them from going cold, and evacuate. And I'm not sure there's a great deal more that needs to be said about that necessarily. Anything you want to add anything to that?
You mentioned pain relief. Could we use Entonox to start with, if in intermediate, and then move on to the harder drugs, or?
Yeah, that's a good question. So, I don't. As long as there's no significant lung injury, so no significant inhalation injury, if it's just a skin injury, I can't see any reason why Entonox would be contraindicated. So one of the main things about Entonox is that if there's any potential pneumothorax, if air is in the wrong place in the chest, then Entonox is bad news. Now, to my knowledge, I don't think you can get a pneumothorax from an inhalation injury, but it probably, common sense might rule that, if you're out in the middle of the sticks, let's not give them a rapidly inhaled drug if you've got an organ that's injured. So if there's an inhalation injury and we think there's maybe soot, so it's probably worth sorry. So in terms of inhalation injury, one of the main ways that we can talk about this, if there's soot or any singe marks in around the nose or the mouth. So if there's any suggestion that there's been a significant inhalation injury, I'd probably avoid it. But other than that, if it was say an isolated, leg burn or torso burn, yeah, I think it would be reasonable. I'll have to double check, and I'm happy to stand corrected, but I don't see any obvious contraindication.
Thanks.
Just one thing on the cooling. Possibly in the mountains, you might have access to a mountain stream. Would that be the lesser of two evils? Potential risk of infection and not sterile water, but rapid cooling. Would that be the lesser of two evils?
Yeah, I think so. Because I think that your description of a mountain stream is pertinent, isn't it? Because
rather than a muddy puddle, I'm thinking a mountain stream.
Yeah. So yes, I think that would absolutely be an appropriate way forward, because at the end of the day, what you're doing is you're taking potentially viable skin that can still have that still has a blood supply and still works as a functioning organ, and you're trying to stop it from turning into a destroyed skin, which allows infection to happen. And at the end of the day, I guess these casualties are going to end up in hospital, and they're going to be administered lots of antibiotics, regardless. So there's going to be some, at the end of the day, some antibacterial cover given by the medical teams. So yeah, I think that the mountain stream scenario, absolutely, I'd use that liberally.
Okay, cheers.
So I've got another one on airways and fentanyl. Would that be the same thing with fentanyl if they've got some kind of burns? Because we don't, we're running low on nasal diamorph and intramuscular morphine, aren't we? So
yeah, so I would probably apply the same principles. So I think that the fentanyl lozenges would be a really appropriate use for burn pain management. I think that if there's a lot of suggestion of an inhalation injury, the question would be would you be absorbing the fentanyl that effectively anyway? But if there's significant concern over an inhalation injury, I'd probably be trying to find alternative ways. So intramuscular, ideally. I'm not saying that it's a contraindication. I'm just saying that I think there may be alternative first choices.
Okay, thanks.
Anything else on that? Okay, fine. We don't really cover burns that frequently. It's been a long time since I've even thought or read much about it. So it'd be interesting to see what the thought processes would be behind some of the other medics in the teams. If you guys, I don't know if anyone's here, but if you guys end up going back to your teams, by all means have the same discussion with them. But those have been my sort of basic principles. Fine, so we'll go from one extreme to another, again keeping it nice and fluid and dynamic. I've provisionally put us down to sort of working towards 9 o'clock-ish. If I find a natural break, I'll take it. But if people are starting to peel off like flies, then just let me know and we can stop it earlier. Otherwise, I just thought I'd make the most of getting people online and go till about 9 o'clock-ish. So hypothermia. So this is a really important one for your written paper, and I suspect that there will be several questions on hypothermia. So having a good awareness of this is particularly important. Certainly in terms of active treatment on the hillside, it's something that some of the Scottish teams would have to be very familiar with. I suspect that some of the teams like Llanberis and Ogwen would have potential some exposure to. Some of the other teams maybe not. But certainly for the written exam, this is going to be really important. So this is all based around a document written by MREW around about hypothermia. Now, there's a few documents that I keep mentioning, and I'm happy to send them round if anyone wants them. I know that my team, if they haven't got them already, they'll have them shortly. So I mentioned the overall MRAW syllabus as number one, and then secondly, I've mentioned the MRAW hypothermia guideline. So these are nice things to have as PDFs on your phone, ready to be looked at. So we base it around this sort of Swiss staging of hypothermia, where we categorize how cold someone is, and we try and work out what grade they're in to help us determine how poorly they are, and their risk of death or their risk of survival. Now, there's temperatures here. Now, we don't carry thermometers. Well, most teams don't carry thermometers, but they're there more for you as a guide to understand. As a guide. Sorry if you can hear my wife singing while she cooked her dinner. I do apologise. I might just shut the door. Oh. She's clearly very happy that she's got the evening to herself. We've got so stage one, so clearly conscious and shivering. So if we call a normal temperature around about 36 degrees, so we're just under that. Then we've got, and that's a mild hypothermia, and I'm pretty sure that we've all encountered that ourselves. I'd be very surprised if any of you hadn't been at stage one at some point in your life. Next, we've got stage two. This is where our conscious level is starting to become impaired, so we're becoming quite drowsy, and then we start to lose the function of shivering, and this is starting to become a really worrying sign. So shivering, the actual process of shivering is where you've got really intense muscular contraction. So your muscles start to contract and release, and by doing that, it generates lots of heat, and that's what keeps you warm. Now, if you're cold and you're shivering, but then the shivering stops, it usually means one of two things. So one is that you've warmed yourself up, or two is that the body's starting to lose the ability to shiver, and that can often be because it's starting to use up the fuel supplies, so the energy and the sugar in the body to be able to continue the muscles contracting, and therefore the body's starting to lose its protective reflex. So this is when things start to get a little bit hairy, because you're just starting to teeter on that slope of someone becoming really quite sick, because as soon as the body stops being able to protect itself, you then start the rapid cycle of continued heat loss, unless you can get some external factors in to help warm the body up. Stage 3, they're now unconscious, but you can still feel the pulse and they're still breathing. So obviously this is really serious stuff. Stage 4 is where essentially the body appears like it might be dead, but actually there's either a very, very faint or very, very slow pulse, the occasional breath. So we're not talking about a normal breathing rate, we're not talking about a normal heart rate. We may be talking about 10, 15 beats per minute. We might be talking about a couple of breaths per minute. So the body's in a complete shutdown state, and we're essentially cold to the state that we're beginning the process of dying, and that will happen in due course. And then stage 5 is where the body has died, and it's no longer irreversible. And then there's this really weird temperature of 13 degrees, which is where that cutoff is, and the only reason that cutoff is there is because that's the lowest temperature that the human body has been resuscitated from. It's not to say that the body couldn't be resuscitated from below 13 degrees, but that's the lowest recorded. And I think it was I forget the exact story, and someone can correct me, but I think it was a Norwegian anaesthetist who was skiing and went through a crevasse and got immediately submerged immersed, not submerged, into very, very icy cold water, got immediately chilled down to a very, very low temperature, and then was transported to the hospital where she was resuscitated from, I think it was about 13.4 degrees in her own hospital, which must have been quite a strange thing to happen. So anyway, there you go. That's just a little bit of knowledge tidbit to go with that. So those are your rough 5 stages, and they're very useful to be aware of. So what we're going to do for someone who's cold, so let's face it, the majority of patients, casualties we're going to see, you know, I'm sure some of you have seen some already this year on the hillside at stage 1. I'd be surprised, but certainly, and it's worth saying that, you know, people in summertime can reach stage 1. Some of the teams may have seen some sort of stage 2 this winter gone by, and I'd be surprised, but only because it's just less common that we're able to find and treat these patients. But some of the teams may well have seen some sort of stage 3 hypothermia. So what we're going to do, we're going to identify, but realistically, we're going to treat them all relatively the same as much as we're possible. So it's all about protecting the heat that's going around their body, stopping them from losing any more, and then trying to offer them some sort of external heat. So whether that's using other body heat, huddling together, lying in a kizu with lots of people around, applying oxygen depending on how cold they are, but obviously generally the principles are the more unwell somebody is, you know, just put them on oxygen. There's very rare a situation where putting oxygen on someone is a wrong answer, unless they're actively on fire. I suppose that would be one for the burns talk. Providing them with quick release glucose, so glucogel, or which would be our kit, what we carry in our kit. But if not, you know, any quick release sugar, so, you know, sort of like dextrose tablets, or even just a chocolate bar with some quick release carbohydrate, because what that does is that just pools a load of sugar into the bloodstream and gives the muscles more fuel to work with. The guidelines talk about measuring temperature either by the mouth, an oral temperature, or an ear temperature. That isn't really routinely done. The guidelines were actually written by the Lakes District group of teams who carry slightly different kit, probably due to slightly different funding streams. But certainly for our team, I don't know about Llanberis, but certainly for our team, we don't carry a thermometer for casualty use. Protect the airway if necessary. So if they're cold and their conscious level is decreased, it's a way of stopping that obstructed airway that we talked about before. So if we start to hear snoring, we might want to think about putting an airway adjunct in. Rapid evacuation, so only removing wet clothing under shelter. So, you know, once we expose skin, we don't want you know, wind then exacerbating heat loss by blowing next to exposed skin, especially when it's wet, as you're going to get evaporation that will draw more heat off the skin. And then this sort of point, so there are a few sort of specific and quite niche points about hypothermia, and this is one of them. So when you reach the stage of severe hypothermia, so this sort of stage 4, and I guess to some degree it's probably good practice to practice it with stage 3, but essentially the casualty has to be managed completely horizontally, and that includes in terms of evacuation if by helicopter. If you start to tilt the body head up, head down, then you get large shifts of cold and slightly acidic blood, and if you get a large shunt of that blood back up to the heart, it can then irritate the heart muscle, and it can trigger electrical problems and put them into cardiac arrest. So it's important that the casualty is managed horizontally, and big sudden movements are avoided. So that's important for sort of stretcher carrying and casualty manipulation on the hill. Probably the most important thing for your written exam when it comes to hypothermia is the distinction of is a casualty in front of me, are they severely ill because of hypothermia or severely ill because of something else? So let's just go over some scenarios. So these are three sort of relatively not common, but the most likely scenarios. So an avalanche, so you get it immediately compacted into a really cold substance. Cold water immersion, so immersion rather than submersion, because obviously if you're submerged, then you're going to begin the process of drowning because you're having water going into your lungs. So if the body, not the airway, is underwater, get much quicker heat loss. And then finally, exposed to the elements for a prolonged period of time. So fell runners out in bad weather, drunk people who go out and they pass out on Christmas Day and fall into some snow and lie there. These are the more sort of common scenarios that we might see. So let's just say so avalanche rescue is one that gets talked about quite a lot in mountain rescue for obvious reasons. And there's a few buzzwords that they'll always mention. So one of them is that the casualty was or was not found with snow packed in their mouth and their airway. And then number two is that there was or was not an injury that was incompatible with life. And the reason for this is that if we take the scenario of an avalanche casualty, so when you do your avalanche training, you're putting your probing sticks down, and you find a casualty, and you free them up from the snowpack. There's a few really important things that we're looking out for. So one is we're looking for an air pocket. Two is that we're looking for snow in the airway. And three is we're looking for injuries that are incompatible with life. And the reason for this is that casualty, if they are unresponsive, if they are lifeless, so they haven't got a pulse, they haven't got a respiratory rate, their mechanism of death is one of two things, or one of three things. So it's either they've slowly cooled down and they've died because their body is cold. It's because they have their airway is sort of filled with snow, and they've essentially sort of asphyxiated. Or three, that there may be some trauma from the avalanche itself that may have caused another mechanism of death. So we're talking about bleeding into the abdomen, or amputation of the limb, or a broken neck, etc., etc. And the reason why it's always important is because there's actually nothing we can do for any of those scenarios apart from if someone has died as a result of cold itself. Because if they've died of cold itself, then we're going to try and actively resuscitate them for as long as it requires, and that may be an hour plus, depending on the scenario. So if there's an air pocket and you find them, the air pocket indicates that that when they were caught in the avalanche and settled, that there was a period of time where they potentially were still able to breathe. If there's snow in the nose and the mouth, that indicates that after being hit by the avalanche, there was never really any chance where they were able to continue breathing. So they would have asphyxiated before they died of the cold. And obviously, if there's major injury, then that's an indicator that they've died from something else. And why this changes our management is, as I said, if we think that this casualty has died from hypothermia alone, then we're going to extract them, and we're going to attempt to resuscitate them for as long as required. And the phrase "you're not dead until you're warm and dead" comes here. Because we want, in an ideal setting, you would transport that cold casualty who's died because of the cold into a hospital environment, and you would resuscitate them, and you would continue to try and resuscitate them until they reached relatively near body temperature, because it's actually near impossible to successfully resuscitate someone when they're that cold, because the heart is too electrically irritable, and you just can't get it to restart. Does that make sense? I think I've waffled a lot there, but I hope you kind of appreciate the point I'm trying to draw there. Does that all make sense? Does anyone have questions on that? Okay. So moving forward, so then if we think that the casualty has died from a hypothermic cardiac arrest, then as we said before, the normal rules don't apply. So we're going to continue doing CPR until the casualty gets to hospital. We're going to try and do continuous CPR on the hill if possible. That may require multiple team members to take over. If you don't have multiple team members, then we may have to practice intermittent CPR, which is suboptimal, but it's a way of doing an on and off situation. It's very ad hoc, there's no science behind it, where you do CPR for a period of time, break, transport, CPR, break, transport. And the MROW hypothermia guidelines got a bit more information of that. We talked about managing the casualty horizontally. If we put the AED on, so they're in cardiac arrest, and we go through our BLS algorithm, and part of that is putting our defibrillator on to shock them. If the defibrillator identifies a shockable rhythm, then we only do 3 shocks and then we stop. Because the heart is so cold, it's unlikely that the electrical abnormality in the heart is going to be corrected, and so therefore we're just going to cause lots and lots of damage to the heart and the skin by shocking and shocking and shocking. So we stop, and then we'll only retry shocking them when we've managed to warm them up. And that's about it really for hypothermia. So it's a bit of a specific and niche topic, but it's one that will come up on your written exam. So yeah, any questions on hypothermia? Fine. Only because I can't see the screen. You are still with me, aren't you?
Yeah, we're still here.
I'm not just talking to myself. Fine.
Yeah.
Yeah, still here.
So that's hypothermia. So a really important one for you to be aware of. And then what we'll do is we'll just talk about cold injury, heat injury, and then we'll assess the diet. We'll assess the room for talking about lightning strikes. Because I don't want to fatigue you all. So hypothermia is where the whole body gets cooled and chilled down, and as a result causes significant harm to the body. If the core temperature remains okay, but you've got your peripheries that have become more exposed, then you get this sort of cold extremity injury. So it's what we refer to as frost nip or frostbite. Some of you may have experienced frost nips, some of you may have experienced frostbite. It is a more serious abnormality. And basically, this is on a spectrum of disorders it's caused by soft tissue damage due to the cold. So frost nip is reversible. It's the very, very sort of earlier stages, up to sort of about 30 minutes, where you get quite extreme exposure to cold. You can start to get some skin changes. They start to become painful. You might start to, or alternatively, you might start to have a reduced sensation. You might start to swell, and then this will progress in time to more numbed, dead skin. There might be whitening of the skin. These down here in the bottom right hand picture, this picture of these black toes. That's what people refer. People often think, well, that's what frostbite will look like, and that is what frostbite might end up looking like. But that's more of a later stage process, because the black indicates dead. Skin that's been dead for a bit of time. So that's not really kind of something we're necessarily going to see on the hillside. That's something that will be seen in the days to come. Things that will increase the risk of cold extremity injury. So when people get older, or so young people, older people who can't regulate their temperature as well. If there's people who've been drinking alcohol, so again they can't regulate their temperature as well. Smokers and diabetics who may have poor blood supply to their hands and their feet through the damage that these things cause. These people are more at risk. The treatments, again, like relatively straightforward stuff. Focus on the core warming. So don't go and put a heat pack on their hand. Work from the centre outwards. So warm up their core, keep their hands covered in loose warming garments, so nothing tight, so a tight glove or a tight sock, they're just going to restrict blood flow even more. So nice loose clothing to the hands and the feet. Things like mitts, for example, are ideal for the hands. Take off jewellery before it's too late, and that pretty much applies to any injury to any limb. If someone's got an arm or a leg injury and there's jewellery on there, it's always good practice just right early on get the jewellery off, because you just never know whether there's going to be swelling later on. And if swelling occurs later on and you can't get the jewellery off, it then becomes far more difficult and troublesome. So core rewarming and nice loose warming strategy, and that's about it. And it can be painful as well, so good use of pain relief is sensible. I'm not sure there's much more to be added to that, really. Anything you want to ask about that? Fine. So takeaway messages for the exam in terms of cold injury. So simple basic principles work best. In terms of the hypothermia cardiac arrest, so assess the mechanism of injury and resuscitate if the mechanism of injury is thought to be hypothermia. So if they've died from asphyxiation by the snow in their mouth and their nose, if they've died because of trauma to elsewhere in the body, these patients are not going to be good candidates to resuscitate, but we are going to give the casualties who we think have died purely because of the cold our best chance. And it's not going to be easy to determine this, is it? So it's not black and white. You're not going to drag everyone out and make a decision and say, right, this casualty has definitely died of hypothermia, therefore we're going to try and resuscitate them. It's more that we're trying to exclude any big obvious flags that suggest that they died from another mechanism before we proceed. So we'll have a reasonably high threshold to crack on and resuscitate them, but we'll have a mindset of look, if there really isn't any point, then let's not use our resources in that way. In terms of thermal stuff, we may as well just finish off this section by talking about heat illness. So again, this is a spectrum. So it spans from heat exhaustion to heat stroke. Heat exhaustion being the initial reversible injury to the body due to being too hot. So essentially, the body is generating too much heat that it can get rid of, and that can be to a variety of factors. It might be because of the environmental conditions. It might be because we're exercising to a very high capacity that the environmental conditions mean that we can't lose the heat quickly enough. And the symptoms to begin with are quite non-specific, so headache, tiredness, dizziness, confusion, and this will progress into more sinister symptoms, sort of becoming unconscious, that really we've got this rough idea of 30 minutes where we can stop this irreversible damage from happening. So simple cooling measures are what's really important. So stop the exercise, get them out of the sun, get them out of direct sunlight, take off excess layers. Lots of oral cool drinks, so nothing too cold. There shouldn't be any sudden shocks to the body, but some nice cool drinks. Spray the body with again cool water, or pour cool water over the body to allow it to evaporate off and draw heat away from the body. If they're becoming dizzy or lightheaded, it may be because all the blood vessels have expanded and your blood pressure's dropping. So lie them on their back and put their legs in the air to redirect all that blood from their legs back towards their heart. And just be slightly more cautious about those who are higher risk. So those who are higher risk are the same as with cold injury. So older people, younger people, people who can't regulate their bodies as well, people who might be on a variety of tablets for other problems like high blood pressure, diabetes, and that's about it. So lots of simple stuff done well. We're going for about an hour and 40 now. And as much as I'd love to talk into the night time, I am conscious that it's probably getting a bit mind-numbing for you guys. So the next topic's a lightning strike, and then moving on to some injuries from insect bites, snake bites, and then a few other miscellaneous items. So why don't we see what questions are there to be asked, and then we can make a plan from there. So does anyone have anything they want to ask at all? No.
Patrick, are there past papers available?
No, unfortunately not. Only because the rules are that we're not allowed to share past papers. So what we certainly can do is we can make some up that seem plausible, but I can't show you any direct past.
Because the last exam I did was in the old format, so I'm not aware of the new format in the same way.
So when you say the old format, the old format you did was only 3 years ago.
Yeah, I thought it had been updated.
No, not to any significance. It's still going to be a stem of a question and then a choice of 4 or 5 multiple choice answers.
Okay, fair enough.
And in terms of there was a question, there was a vicious rumor going around that the exams have got harder. The latest discussion has been is that everything's pretty much the same. I don't think you'll notice any difference.
Okay, thanks.
Anything else at all? Fine. Does anybody particularly want me to carry on, or is everyone happy to I mean, I'm just conscious that once you get started on the next topic, it could be another 20 minutes or so, and I'm conscious that I'm eating up into your evening.
I mean, I think you need a break as well.
Oh no, I'll do whatever everyone wants. I just don't want to. You need to be conscious to be able to take things in, and it can be quite mind-numbing.
I'm going to dip out because we might have a job going on, so that's all right. Thanks for tonight. It's been great.
No problem at all.
I'll see you in a bit.
Yeah, much appreciated.
Right, well, we'll draw things to a close then. If people are starting to peel off, that makes fine. First thing I'm going to stop this recording.